You ready to go? Okay. Okay.
All right, so shall I begin?
Yes.
Okay. Hello, everyone. My name is Mohammed Qasim Bhatti. I'm a final year medical student at the Royal College of Surgeons in Ireland, stationed in Bahrain. And my topic for today is ischemic stroke. So let's dive right into it. So here's the table of contents. Usually what I do is I start off with a question, and then I'm going to go a bit more on the background and epidemiology, the etiology of ischemic strokes, the pathophysiology, the clinical features, and to finish it up with the management. And I'm going to try to keep it short. In terms of the management, I might go into a bit more detail because I feel like it's pretty vital, especially in ischemic strokes, because it's time dependent. And it's essential to have a comprehensive understanding of the management. So let's start off with the question. So here you have a 65-year-old man that is brought to the emergency department an hour after his wife noticed during breakfast that the right side of his face was drooping. He has type 2 diabetes mellitus, hypertension, and hypercholesterolemia. His current medications include metformin, enalapril, and atorvastatin. He has smoked 1 pack of cigarettes daily for 40 years. He's alert, oriented to time, place, and person. Temperature is 37 degrees, pulse is 93, blood pressure is 167 by 100. Examination shows equal reactive pupils, but there is drooping on the right side of the face. Muscle strength is decreased in the right upper and lower extremities. Plantar reflex is upgoing. Speech is dysarthric. There's a bruit on the left side of the neck. Fundoscopy shows no abnormalities. A CBC, coagulation profile, serum glucose, and electrolytes are all within normal limits. Which of the following is the most appropriate next step in management? So I'm going to go into the management later on in this presentation, but this question sort of summarizes pretty well in terms of the classic presentation and why certain tests are being done. Now, as you can see that in this case, there's drooping of the right side of the face. There's a bruit on the left side of the neck. Fundoscopy shows no abnormalities. Now, when you read that, you would think that, okay, if there's no abnormalities on fundoscopy, that's most likely there is no raised intracranial pressure because you can't see any papilledema. So that would most likely exclude a hemorrhagic stroke. But we need to do a test to exclude a hemorrhagic stroke because you want to initiate treatment. And as I mentioned before, treatment for ischemic stroke is time dependent. So the first and foremost thing that you do is a non-contrast CT head because you want to exclude a hemorrhagic stroke. And non-contrast CT is the best modality to visualize brain bleeds. So let's go into the background. So what is stroke? Essentially, stroke is a neurological deficit that can be caused either by ischemia or by hemorrhage. There are 2 types of stroke, either ischemic or hemorrhagic. I'm going to go into the details for ischemic strokes later on because that's the topic, but I'm going to give you an overview of hemorrhagic strokes. Now, hemorrhagic strokes comprise 15% of all strokes. And of hemorrhagic strokes, you have intracerebral hemorrhagic strokes or subarachnoid hemorrhages. In intracerebral strokes, that's most likely due to either a hemorrhage within the penetrating arteries. An example of that could be hemorrhage in the internal capsule, which would lead to a contralateral motor loss. An etiology for a subarachnoid stroke is most likely a hemorrhage from a Berry aneurysm, and Berry aneurysms usually occur on branch points at the circle of Willis. The most common branch point is at the branch point at the anterior communicating artery. The second most common is between the MCA. So that's sort of an overview of hemorrhagic strokes. And in physical examination, you would most likely see signs of raised intracranial pressure, and there are certain etiologies that I'm not going to go into detail for for this presentation. So let's dive into ischemic stroke. In terms of ischemic strokes, so the definition is it's cerebral infarction leading to hypoperfusion, which results in ischemia and neuronal cell death. Now, the epidemiology, it comprises 85 to 87% of all stroke cases. So this is by far the most common type of stroke. It's more common in males than females, and there are certain risk factors. Age greater than 65, being from African American descent or Native American descent, hyperlipidemia, hypertension, obesity, family history of cerebrovascular accident, cardiovascular disease, alcohol, tobacco use, migraine with aura, genetic disorders such as sickle cell disease and coagulopathy. So if let's say a patient has thrombophilias, or if they have issues with homocysteine metabolism, that can also lead to an ischemic stroke. This list, by the way, for risk factors is by no means exhaustive, but these are the most common ones that you might see in clinical practice. Now, in terms of the etiology of ischemic strokes, you have embolic and thrombotic. These by far comprise the main gist of ischemic strokes. In terms of embolic strokes, you have cardiac emboli. So an example of that would be a patient that has atrial fibrillation, and you would have mural thrombi from the left atrial appendage that will be launched into the brain circulation. Another example could be a patient that has rheumatic fever, chronic rheumatic fever leading to mitral stenosis, which can again cause mural thrombi formation and leading to ischemia in the brain. Atheroemboli is commonly location at the common carotids by bifurcation, and you have emboli from the common carotid area that is launched into the brain circulation. In terms of thrombotic causes, the main cause is atherosclerosis, which is essentially a rupture of, you'll see rupture of an atherosclerotic plaque leading to thrombus formation. Other causes that I had described before were coagulopathies, genetics such as sickle cell, iatrogenic. So let's say if a patient is on oral contraception, that might be a factor that can play into an ischemic stroke. Certain common subtypes and variants that you might see clinical practice, lacunar strokes in which the cortical signs are going to be absent. So cortical signs are usually aphasia, apraxia, hemianopsia. So in terms of that, you won't see those in lacunar strokes. And you also have watershed infarct. So let's say if a patient is under hypovolemic shock, or you have bilateral large vessel occlusions that can both cause a watershed infarct. Now, in terms of a watershed infarct, I've added this image here. So you have in this image, in the top two images, big A and big B, those are flare sequences MRIs, and the area in blue is the watershed zone. So those are border regions. The upper border regions you can see are between the frontotemporal lobe, which is the area supplied by the anterior cerebral artery, and the middle cerebral artery, and then around the area below is around the occipital lobe, which is by the posterior cerebral artery and the anterior cerebral artery, posterior cerebral artery and the middle cerebral artery. And that is a watershed area. In big B, you can see another watershed area in the deep penetrating, around the deep penetrating arteries, which are branches of the MCA. Now, in those, in the images below, small a and small b, that is a diffusion weighted MRI, and you can clearly see diffusion weighted MRIs are one of the best. I think it's the best modality to see ischemia, and you can see clearly there's an ischemic center around the around the occipital lobe. So let's go to the next slide. Now, in terms of pathology, this is something that the boards love to ask, and I'm pretty sure people that have done their steps by now, they love asking this. So time from initial ischemic insult. So from initial ischemia, the first 12 to 24 hours, you will see red neurons, which is essentially is an eosinophilic cytoplasm and pycnotic nuclei. 1 to 3 days later, you would see neutrophilic infiltration with liquefactive necrosis. So in the brain, you get liquefactive necrosis, not coagulative. 3 to 5 days, you would see macrophage infiltration, which and the macrophages in the brain are microglia, and they'll be positive for the CD40 marker. 5 to 15 days later, you will see reactive gliosis. Reactive gliosis is mediated by astrocytes. 15 days, greater than 15 days after the infarct, you'll see glial scarring and cyst formation. Now, in terms of the clinical features, you see focal neurological deficits, and these all vary depending on the brain and the region blood vessel that is affected. And I'm going to go into a bit of detail about what features you would suspect depending on the blood vessel that is affected. And you can also get certain non-specific symptoms such as nausea, vomiting, headache, and seizures. These are more pertinent towards hemorrhagic strokes, as you would get raised intracranial pressure. And it's important to localize the lesion because that can help guide your therapy. Now, this is the table that that you would want to know and you would not want to know in terms of how to, so that you can localize the brain lesion. So acute ischemic strokes, according to vascular territory, if the anterior cerebral artery is involved, you will see motor and sensory deficits more in the leg and the face compared to the arm. In the MCA, if the dominant hemisphere is effective, you'll see aphasia. So there's certain things that you would want to remember in terms of distinguishing which area is affected. In the non-dominant hemisphere, you would see hemispatial neglect. In the posterior cerebral artery, you would see homonymous hemianopsia, but you would characteristically see macular sparing. Penetrating vessels, that if it's in the posterior limb of the internal capsule, you will see poor motor hemiparesis. And I went into it. I described this previously in one of the previous slides. If it's a vertebral-basilar stroke, you would see cranial nerve palsies, sensory deficits, ataxia, dysphagia, motor deficits, depending on where exactly the location is. And if it's the internal carotid artery, you would see a stuttering onset of an MCA syndrome and could possibly have an ACA syndrome. And so this image describes the major major regions that are supplied by those relevant blood vessels. So you can clearly see, according to this image, the ACA is usually around is more located medially, whereas MCA expands medially to laterally in the medial to lateral cortex. And we all know the circle of Willis and the major branches off of it. There are a few branches that are not displayed in this picture. So a posterior inferior cerebellar artery, if that is being blocked, you might get a lateral medullary syndrome, and if it's an anterior inferior cerebellar artery, then you might get a lateral pontine syndrome. I'm not going to go into the brainstem syndromes, but that's also relevant, and the management of all is the same, and it is time dependent if it's an ischemic stroke. So certain classical presentations. A middle cerebral artery infarct will typically present with contralateral hemiparesis, contralateral hemisensory loss, contralateral central upper motor neuron facial nerve palsy. So if that happens, you'll get your lower half of the face would be affected because the upper motor neuron is supplied bilaterally from the facial nerve nucleus. Aphasia if the dominant hemisphere is affected, as I had mentioned previously. An anterior cerebral artery infarct typically leads to contralateral lower extremity weakness, contralateral sensory loss, urinary incontinence. And a PCA infarct typically leads to contralateral sensory loss, contralateral homonymous hemianopsia with macular sparing. Now, this is the management. So in terms of management, I've mentioned this, it's time dependent. You want to rapidly assess the patient, rapidly determine the patient's eligibility for thrombolytic versus mechanical thrombolytic therapy versus mechanical thrombectomy, and rapidly initiate treatment because that will drastically impact their outcome. This picture is a really nice algorithm that I got off of the AMBOSS library, which describes it in great detail. I'm just going to go into it's the ischemic stroke protocol because that's the main focus of this presentation. Whenever you suspect stroke, like whenever there's a clinical suspicion of stroke, usually there are dedicated stroke centers that activate the cold stroke protocol. A cold stroke protocol is activated. There is rapid evaluation following an ABCD approach, airway, breathing, circulation. You would rapidly perform an NIHSS scale, which the NIHSS scale would quantify the severity of the stroke based off of levels of consciousness, ability to follow commands, cranial nerve deficits, language impairment, etc. And it is out of 42. And the higher the number is, the more severe the stroke is. So that is the rapid assessment. And in that rapid assessment, you would also do a series of blood tests. You're gonna rapidly order CBC, INR, baseline troponin, serum glucose, O2 saturations. Serum glucose is really important because both hypoglycemia as well as a hyperosmotic hyperglycemic state or DKA can mimic stroke symptoms. And you would do an ECG if the patient might have a concomitant MI or AFib. Now, let's say if these symptoms have resolved within 24 hours and are reversible, that is a transient ischemic attack, and you would think of secondary prevention. But if those symptoms are ongoing, then this is most likely an ischemic stroke and time is of the essence. You want to emergently do a non-contrast CT to rule out hemorrhage. And if there is no hemorrhage, that is an ischemic stroke. You want to determine the eligibility for recombinant TPA or alteplase. I'm going to go into a bit more detail of that in the next slide. And if they are eligible, you initiate recombinant TPA or alteplase. And 24 to 48 hours later, you would start them up on antiplatelet therapy. 24 to 48 hours after they have had the TPA, not before that, because if you do that, you can change an ischemic stroke to a hemorrhagic stroke. And you would, and for patients that are not eligible for TPA, you would consider neurovascular imaging, so such as MR angiograms or CT angiograms to determine the candidates, the patient's eligibility for mechanical thrombectomy. So let's say if you see a large vessel occlusion in the anterior circulation, or you can, they might be eligible for mechanical thrombectomy. Sorry, I'm just going to go back 1 second. This flow chart from the 2018 AHA ASA guidelines, it was one of the quick sheets, really summarizes it well in terms of how to manage ischemic stroke from triage to the inpatient setting. So you want to first recognize, and by bystander, you all know, okay, FAST, so facial droop, and facial droop, arm weakness, speech difficulties, time to call 911. You do that. If it's positive, first medical contact. In the emergency department, you as I mentioned, you do at the NIHSS scale, which is out of 42. You do immediate rapid diagnostics and blood tests, and then you determine the patient's eligibility for thrombolysis versus mechanical thrombectomy. Now, the criteria for thrombolytics. The inclusion criteria is an ischemic stroke with focal deficits. Symptom onset should be within 3 to 4.5 hours. And there are absolute contraindications if the patient has had a recent ischemic stroke or had trauma within the last 3 months, a history of intracranial bleeds within the last 3 months, elevated blood pressure greater than 185 or 110, low platelets less than 100,000, or glucose that's less than 50 mg per deciliter. There are relative contraindications such as a GI bleed or malignancy within the last 21 days. I forgot to write that here, but it's within the last 21 days. There are also other contraindications that I haven't mentioned here, but you feel free to look those up as well. So the goals for treatment. You've probably heard of this. Time is brain. That's what everybody says in terms of ischemic stroke management. You want to rapidly assess the patient for eligibility for either a thrombolytic therapy versus mechanical thrombectomy. You want to keep your door-to-needle time short, very short. And these days, door-to-needle time for most stroke centers is less than 60 minutes. And that's what the AHA recommends as well. There was an initiative that was started back in 2010 called Target Stroke, and they had recommended to keep door-to-needle times less than 60 minutes for at least 50% of the less than 60 minutes for at least 50% of the patients. So as I've said, time is of the essence here. You want to initiate neuroprotection, which is and subsequent stroke prevention and supportive therapy. So you want to monitor the patient's blood glucose, hemodynamics, fluid balance. If they're put them on a sliding scale, if they're diabetic. In terms of stroke prevention, you want to initiate aspirin or dual antiplatelet therapy after the first 24 hours. You want to do supportive therapy, which would be post-stroke care as well. So DVT prophylaxis, dysphagia screening, liaise with the multidisciplinary team in terms of starting physiotherapy and other treatment modalities. So this is something that I had done in one of my affiliated hospitals, the affiliated hospitals to my university, and we had done a quality improvement study, and we sort of looked at the major variables, the major guidelines that the hospital was following, and these guidelines were recently updated in the 2019 publication. So here, in conclusion, acute ischemic stroke care is time dependent, and rapid recognition and treatment is essential to reduce morbidity and mortality. Post-stroke rehab involves a multidisciplinary approach. You want to do dysphagia screening, you want to liaise with the social worker, you want to liaise with occupational therapists, physiotherapists, and start them up on enteral feeds, post-stroke care. So it's really, really important to do that in a time-dependent manner to reduce the patient's morbidity and reduce their chances of getting any fearful, any bad neurological sequelae after their episode. So that is my presentation. Thank you so much.
Thank you very much.
And these are the references.